In 1999, HIV was declared a national disaster in Kenya. Awareness about HIV has increased over the years. More people have been tested and begun treatment, bringing down the number of new infections and prevalence rates.
At the moment, we estimate that by the end of 2013, there were about 1.6 million people living with HIV, with a prevalence rate of 6%. And that is an improvement because some 10 years ago, the prevalence rate was 13%.
The management and treatment of HIV/AIDS in Kenya is heavily reliant on donor funding. Recently, there have been cases of donors pulling out or downscaling their funding. This has caused adverse effects on the people who relied on the funding. One of the areas affected by donor pullout is Mbirikani in Loitoktok, Kajiado County. About 2 years ago, this place was bustling with activity. But right now, it's a shell of its past.
Nilifanya biashara hapa Mbirikani kwa muda mrefu. Sasa hii biashara ni ngumu sababu kulikuwa hospitali hapa ilikuwa tusaidia sana. Kibiashara wagonjwa walikuwa wanakuja huku wanalala, lodges inajaa, madukani wananunua maziwa, sukari na kila kitu. Lakini kwa sasa hii biashara hakuna baada ya hospitali kwenda.
Watu wengi kutoka Tanzania walikuwa wanaenda hospitali ya Mbirikani kuchukua madawa, lakini tangu imefungwa watu wengi wamehangaika kwenda mbali kutafuta madawa, hawajapata. Wamepoteza vitu vingi ili wapate madawa lakini hawakuweza. Kwa hivyo imetupatia madhara mengi sana.
Hospitali ilikuwa inashika tuseme Kajiado South Tanzania na mali nyingine mingi tu imesaidia watu.
About 300 meters from the shopping center is Mbirikani Group Ranch Clinic, a major landmark in Mbirikani village and the entire Loitoktok region. The clinic used to serve the community within and outside Mbirikani area. We meet Samar Ntalamia, the former fleet manager at the clinic.
This place was set up by Muiruri. She's an American lady who came to Mbirikani Group Ranch as a tourist, and she was so moved by lack of very basic and essential healthcare services, especially for women and children. Initially, she set up a trailer outfitted with a consultation room, a lab, and a small pharmacy, going out into very out-of-the-way places to offer medical services where transport was a problem. There were no medical facilities, and then thereafter, she set up this facility as a clinic. The facility is very big. I think at its peak, it was serving over 10,000 patients. It had over 100 staff. I think it had the highest number of physicians in Kajiado district. It had maybe one of the best labs and nearly some of the best healthcare services in Kajiado.
In 2012, the facility was closed down indefinitely when the donor, Muiruri, pulled out.
Muiruri started the facility hoping that somewhere along the way, corporate donors or individual donors would come in and help her show up part of the financial load. When the facility was running at its peak, the operational cost per year was $7 to $8 million, and all this financial load was being borne by Muiruri herself, maybe with a few donations from a few organizations like PEPFAR was supplying some HIV drugs, but apart from that, all the other financial load was being carried by Muiruri herself. The closure of the facility was such a big loss for the local community, the local Maasai community, as well as thousands of patients who are coming from as far as Ukunda. Some was coming from as far as Sudan and Tanzania, just because of the quality of healthcare services that were being offered in this place, especially HIV management and TB treatment.
A walk around the facility further displays the state of the clinic that once served over 10,000 people in the region.
Now, this used to be the kitchen and the dining area where over 100 Mbirikani staff members used to, have their meals from. But right now, the place is just, accumulating dust with nothing much to show. Now, I understand this was the VCT unit where people from this area would come for voluntary counseling and testing. Yeah, the place is deserted.
Close by the clinic is an airstrip where patients with complicated cases would be airlifted to Nairobi for specialized treatment, but right now, it just lies as bare land.
Aircrafts would come, like this was the runway. They'd come and stop here.
A few kilometers from Mbirikani village is Kimana village. Here we meet Christine Wamboi. Christine is HIV positive and has been seeking medical care from the facility before it closed down.
Mbirikani ilikuwa na msaada mkubwa sana kwa sababu hata kwa sasa kuna kipindi tulikuwa na mkutano na madaktari wa Oloitoktok. Wakatuambia walienda Mbirikani na wakapewa ilivyofungwa na wakapewa hizo referral. Wakatuambia kuna referral zaidi ya 1000 na ambazo hawa watu hawajulikani kama wanachukua madawa ama hawachukui. Mbirikani kuna unakuja watu kutoka Tanzania, kutoka Uganda, Mombasa, wapi, sehemu nyingi tofauti. Sasa hawajui kama wale watu kule walikoenda wanachukua madawa ama hawachukui. Pia mimi wanafanya kazi ya community health worker. Kuna wengine mpaka sasa hivi hawajaichukua madawa kutoka Mbirikani ifungwe. Waliacha kwa sababu huyo mtu hana uwezo wa kwenda mbali na mahali anapoishi na hataki kwenda karibu na pale anapoishi asionekane kwamba anachukua zile dawa. Sasa inabidi anaacha dawa na anakaa hivyo. Mbirikani walikuwa wanaletea watu madawa mpaka nyumbani, pengine ikiwa huna uwezo. Pia walikuwa wanalipia watu fare. Ulikuwa unapewa card, unaingia kwa gari, unaenda mpaka Mbirikani unachukua dawa zako na unarudi. Na kama pengine umelemewa uko nyumbani, wanakuja wao wenyewe kukuangalia na pia wanakuletea madawa mpaka nyumbani.
Most of the HIV patients being treated at the Mbirikani clinic were referred to Kimana Health Center and Loitoktok District Hospital.
Ile shida tuko nayo kwanza ni ya madawa. Madawa na service yao iko chini sana, hata inashindwa na hospitali ndogo hii ya Pandi ya Kimana. Kwa shauri ile hospitali ya Loitoktok ile kubwa, madawa hakuna. Hata saa nyingine unaweza kutumwa uambiwe uende Tanzania. Na tuko na hospitali kubwa sana hapa ya Loitoktok.
Our attempts to talk to the county government on what they plan with the facility were futile. So was that of accessing Kimana Health Center. A big percentage of the patients visiting the Mbirikani clinic were HIV patients. And since the hospital closed indefinitely, many of them have been receiving treatment at the available health centers, while others have since passed on. Mbirikani Group Ranch is just one of the many projects that have collapsed after donors pulled out in one way or another, and the effects have been greatly felt.
90% of HIV treatment in Kenya is reliant on donor funding. With the current donor pullout being experienced in the world, the issue of sustainable funding for the treatment of HIV is one that cannot be ignored.
According to a report released in April 2014 by the National AIDS Control Council titled Sustainable Financing for AIDS in Kenya, Forward-Looking Assessment of the AIDS Financing Gap, the HIV/AIDS financing gap is projected to grow from 145 billion shillings in 2010-2011 to 215 billion shillings in 2029 and 2030 period. This means that measures need to be put up to cushion the national response to HIV/AIDS in the face of a decline in international financing and widening financing gap that is projected in the coming years, an issue that the director of Kenya AIDS NGO Consortium concurs with.
The opportunities we have are many, in the sense that the donors are not just cutting the money today. What we are seeing is in the near future, monies will be less and less, and therefore we need to put in a system where we can actually be able to get our own money, just like what we have done in other areas of infrastructure. A good example is in the education sector, where most people used to go abroad for trainings, but right now we have many universities actually across every other country, and therefore we need to actually ensure that our people are put on treatment. We are using our own resources. These are our own brothers and sisters, and there is no reason why any Kenyan should not go on treatment.
Kenya recently launched the new World Health Organization guidelines for the treatment of HIV and AIDS. Patients will be taking medication when their immunity is still high at a CD4 count of 500, up from 350.
When you have HIV and you are put on treatment, you reduce your viral load, assuming you are taking your medication correctly. Because if you don't, then your viral load won't go down. When your viral load is down, you have lesser chance of infecting another person if you had sex without protection. And this is true for cohabiting and married couples. So the more people we put on treatment, we are likely to reap some benefits in the long term by reducing the number of new infections every year.
According to the Kenya National AIDS and STI Control Program, about 700,000 people are currently on HIV treatment, but with the new guidelines, the number is projected to go up to 1.2 million, a move that will call for more resources.
We are moving from largely using CD4 testing to use of the viral load. And we have capacity to do that. We have the support also to do that. We are currently doing it centrally in about 7 laboratories, but over time we are investing in regional laboratories as well. We are also investing in what we call point of care diagnostic machines, where you can do your CD4 and viral load at the health facility that you are going to be checked.
Although the HIV response in the country has recorded increasing financial resources from development partners, the future funding for the AIDS response is increasingly uncertain as a result of changing donor priorities and continuing global economic crisis.
I think we need to know that most of the monies that we have received in terms of responding to HIV, especially treatment, about 90% of that money comes from international donors. This has been good, but it's not sustainable. It's not sustainable because the same donors are looking at the new challenges for the world, especially climate change and new non-communicable diseases that are now being quite prominent, diabetes and a few others. And therefore, we risk to lose the amount of money that we have been used to in terms of responding to HIV.
Yes, it's true that the funding for many programs is going down, not just for HIV, but many other programs. And that has made us start thinking about smart interventions and the way we do business. Because from evidence, we know which strategies gives us results and which one doesn't. Those are writings on the wall. So we also have to up our game in starting discussions for sustainable HIV financing.
Our governments must be able to put more resources than before if we are to sustain the number of people on treatment. We still have to ensure that we go to zero in terms of new infections. We go to zero death. And for that to happen, we still need to put more people on treatment. We need to have more people tested.
HIV/AIDS remains a national disaster and still calls for immediate and sustained action by government and its partners, private sector, individuals, and households. As for the people of Mbirikani, they still hold on to the hope that one day, the clinic that once put smiles on their faces will be reopened.